Well, hello everyone, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event entitled The Second Pandemic, Mental Health Impacts of COVID-19. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also please note that our center, the larger MHTTC network, all use affirming, respectful, and recovery-oriented language in all of our activities. Just a little bit about our center before we get started. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. We encourage you to visit our Southeast MHTTC website to learn more about our center and our upcoming events. A few important notes before today's event. This event is being recorded and will be made available on our website for on-demand viewing in the next 3 days. Using the chat feature. Please remember to select Chat with all attendees if you would like to share your thoughts with everyone. We do have time allotted at the end of our presentation to answer questions. Please submit your question for our speaker using the Q&A feature at the bottom of your screen. Finally, for participants who are interested, a certificate of attendance is available for download after the completion of our evaluation survey. I will now turn it over to Dr. Benjamin Druss so that he can introduce today's speaker.
Thanks, Emily, and hello, everybody. Dr. Ray Kutwicki is the Charles B. West Chief Medical Officer at Skyland Trail, a nationally acclaimed private, nonprofit, residential, and day treatment facility for adolescents and adults with mental illness in Atlanta, Georgia. In this role, Dr. Kutwicki oversees all the clinical, educational, quality, and research activities within the organization. Dr. Kutwicki trained as a Department of Energy Fellow and was a medical scholar at the University of Wisconsin Medical School. He had postgraduate training at Harvard Medical School, the Boston University School of Medicine, and Emory University, where he earned a Master in Public Health degree in Health Policy and Management. He remains an adjunct associate professor at the Emory University School of Medicine. Throughout his career, Dr. Kutwicki has received numerous distinctions, including Emory University's most prestigious Dean's Golden Apple Teaching Award, election to the Alpha Omega Alpha Medical Honor Society, Mental Health America, and Eli Lilly's Heroes in the Fight Clinical Team Award, and the National Alliance on Mental Illnesses Exemplary Psychiatrist Award. Dr. Kutwicki received the Rollins School of Public Health at Emory University's Distinguished Achievement Alumnus Award in 2017 and was named Georgia's Psychiatrist of the Year in 2020. I should add that Ray is a longtime friend and colleague, and we're just absolutely delighted to have him join us for today's talk. So with that, I will turn it over to you, Ray.
Thank you, Ben, and good afternoon, everybody. I want to add my thanks to Dr. Druss, who's been an ongoing mentor and true to Ben for setting the example that he did. You can tell by my picture that one of the untoward ramifications of the COVID pandemic has been a forced change in hair color for many of us. But I'm excited to share with you over the next hour some of the other ramifications of the COVID-19 pandemic from a mental health perspective, both in terms of direct and indirect consequences. Next slide, please. So next slide, please. While I have conflicts, most of which are interpersonal conflicts, I don't have any financial conflicts. Nothing that we talk about over this session produces any kind of financial reward for me. I am a trustee at the Lovett School here in Atlanta, Georgia, and want to disclose that we have been working very hard at that school, like so many of you have, to try to manage the fallout of the pandemic and get children and our students back into class in a safe way. Next slide, please. So during the time I have with you, I hope we can accomplish several goals. Number one, I'd love to describe the association of global uncontrolled inflammation with some mental illnesses. This is a burgeoning theory that many of us in psychiatry are starting to incorporate into some translational clinical aspects of our care for patients. And from my perspective, this is a really new idea that links somebody's physical health with their mental health, which turns out to be very germane in terms of the COVID-19 pandemic. Secondly, I'd like to help quantify the mental health epidemiological impacts of COVID-19 infection on those who are directly infected with the virus. It's quite clear that we have a tsunami of sorts of people who are going to be newly introduced into the American mental health system. And together, I'd like to think through with you how we can accommodate that demand for evidence-based and respectful mental health treatment. Third, I'd like to share with you some of the lifestyle modifications that contribute to poorer mental health or have contributed to poor mental health during the pandemic, and the way that we might be able to prevent those things from further exacerbating the ramifications of the last 18 months in people who have been indirectly affected by COVID-19. And then finally, I want to use my program as sort of a case example of things that we've tried to mitigate burnout within the healthcare workers and to provide continual care to people who are needing mental health treatment, while all of the stressors and the chronic, unrelenting pressures of the pandemic have challenged the staff and our ability to do that. So this is a tall order, and I'd love to jump in and begin our discussion now. As Emily pointed out, please submit your questions through the chat function, and we'll try to get to a discussion about these new ideas toward the end of this hour. Next slide, please. So I want to begin with a survey question, and you'll have an option pop up in just a second, but I'd love to know how many of you know somebody who contracted COVID-19 and either became very ill from the infection or in fact died from the infection. Just a yes/no question. So if you can answer this and then click the submit button, I think Emily or Stephanie will tally the results in just a second. We can get a sense of the lay of the land on how much impact there's been in a direct infection point of view here. So 82% of us have had somebody in our lives who has been really directly impacted with COVID-19. I think that's remarkable, and it sets the stage for why this is such a relevant discussion to have. Next slide, please. And I want to begin sort of making the contention that you can't have physical health without mental health, and you can't really have mental health without physical health. And there's some historical connections that I think all of us are aware of, but I want to draw attention to a new theory about the interconnections between mental and physical health using a theory called the global uncontrolled inflammation theory. Next slide, please. And this theory really dates back to the early 2000s when a multi-center academic trial began showing that there were some pretty significant physical changes among people who had unipolar major depressive disorder. And so the study was designed to look at a cohort of people who had, according to structured clinical interviews, major depressive disorder, and compare physical indicators within that cohort to people in the general population. Given the sample size, other differences related to gender distribution or socioeconomic status or race and ethnicity, or other things that may have contributed to some of the physical differences really washed out in the comparison. And some interesting new physical data emerged. First of all, people with major depressive disorder, on average, have a higher core body temperature than people in the general population. Now, it's almost as if people with depression, particularly subcategories of depression that make it more difficult to treat, almost have what we consider to be a chronic low-grade fever. And at the time that these data were published and being discussed, there was a lot of dissent within the psychiatric community about whether the study was done incorrectly or if there was some kind of confounding factor, because up until that point, we really believed that depression was exclusively a brain disorder and that what happened below somebody's neck really was irrelevant. We're not at the point yet where we're measuring temperature in an individual to diagnose major depressive disorder, but this is a population trend that I think began the further inquiry into physical changes in people with depression. Second, people with major depressive disorder on average have decreased heart rate variability. And so what this means is that it takes somebody with major depressive disorder statistically significantly longer to have their heart rate increase when they're exercising to be able to perfuse their muscles and their brain and their other organs than it does somebody who's equally physically fit but who does not have depression. And the contrapositive turns out to be true as well. When somebody is resting after exercising, if they have depression, it takes that individual statistically significantly longer to have their heart rate return to rest than it does for somebody who's equally physically fit. There'll be some important implications about this finding when we get to some of the behavioral, or what I call lifestyle medicine interventions that have been demonstrated through good research studies to help confer resilience to everybody, whether or not you have a mental illness, who's going through periods of chronic stress. We also know from lab studies that people with depression, especially people with what we consider to be treatment-resistant depression, very frequently have abnormal concentration of inflammatory mediators. It's almost like somebody has an overdrive of their immune system in many cases when folks have depression. And then finally, there actually is a fat redistribution when people go with untreated major depressive disorder. Fat cells or adipose tissue cells pick up from somebody's periphery, their arms and their legs, and they literally move and redistribute themselves to somebody's gut. So what we often see is that there's a sort of chicken and egg argument when people have untreated mental illnesses like depression. It produces these physical changes, including increased obesity, that can further exacerbate depressive symptoms. And we'll talk about that interrelationship in just a second. And then looking at it from the other perspective, we know that people with physical medical illnesses oftentimes have higher rates of depression than those in the general population. Hepatitis B is a great example, especially when people with hepatitis B are treated with interferon, which we'll revisit in a second. They have much higher rates of depression than the general population. Pancreatic carcinoma has been an illness in the media very recently, including a celebrity named Alex Trebek, who recently died from this illness. Over 90% of people who go on to develop pancreatic carcinoma have as their sentinel symptom the symptoms of major depressive disorder. That is to say, they develop the symptoms of depression before they ever know that they have cancer. And so the old way of understanding this interrelationship was that, sure, it makes sense that somebody develops depression when they have pancreatic cancer because they know that they have cancer and the prognosis is quite grim. Well, it turns out that that's not the correlation. It's a biologic precursor to develop depression for many people who have that neoplasm. And then finally, hypothyroidism is a great example. When people have low levels of thyroxine, a hormone that your thyroid gland produces, it mimics the symptoms of major depressive disorder. And in our program, about 8.5 to 10% of everybody who newly admits to mental health treatment has new onset or newly diagnosed problems like hypothyroidism that may be the reason that they're experiencing the signs and symptoms of depression. So the treatment for hypothyroidism is not to be in psychotherapy and to take psychiatric medications, it's to replace your low levels of thyroxine. So this is my argument to you that mental illnesses have a biological pathophysiological association or underpinning, and we're starting to understand the association, even if we don't yet fully understand the causation. Next slide, please. So this is some work, this is a picture of what we're going to sort of term our arch nemesis. This is an electron micrograph of a cell that's part of our immune system called a macrophage. Next slide, please. And the macrophage on this graph is illustrated as that sort of tortuous, translucent blob in the middle of this cell in an illustration that was done with work by our friend Andy Miller. And he's described sort of the innate immunity and inflammatory response of what happens whenever there's a pathogen in our body somewhere. So this could be a bacterial infection. It could be that there's a foreign body in our bloodstream. It could be COVID-19 virus particles. Whatever is in your system that shouldn't be there, if it is recognized by a macrophage, a series of events is produced that becomes important to understand the mind-body connection. So once the toll-like receptors on a macrophage are stimulated with a pathogen, you can see that the macrophage produces some important inflammatory mediators. TNF is tissue necrosis factor, IL-1 is interleukin-1, IL-6 is interleukin-6, and IFN is interferon alpha. And these inflammatory mediators locally produce the classic four things that go along with inflammation: tumor, rubor, calor, indolor, which in Latin mean it gets swollen, it gets red, it gets hot, and it hurts. And those are helpful things if you think about localizing an infection, because what it does is it keeps the pathogen wherever it is when the macrophage recognizes it, so the rest of your immune system can come and clear it out of your body. And people this way don't get systemic infections. They don't develop septicemia or other things that could be life-threatening. But look at what happens when these exact same inflammatory mediators cross the blood-brain barrier and go into somebody's brain. The symptoms that are produced in your brain include fever, fatigue, change in your desire to eat, which we call anorexia, change in your desire to do things that you used to like to do, which in Latin is termed anhedonia, and it changes your sleep patterns. Do those things sound familiar to anybody? We should all be shaking our head, because as mental health professionals, we probably know that these are the symptoms of depression for many people. And maybe up until 15 minutes ago, you thought that fever shouldn't have been on this list, but we have some data that body temperature is affected in some people who have major depressive disorder. So this is possibly the connection between what we're describing as global uncontrolled inflammation and the development of some of the symptoms of mental illnesses like depression. Next slide, please. So this is called the pro-inflammatory cytokine theory, and this is not something that comes out of Ray's head. This is a theory that is gaining traction and actually has been featured in Nature magazine as well as in Science magazine as a link or an association between physical and mental health. We know that when people have uncontrolled inflammation, it increases the risk of the development of all mental illnesses. I've up until now focused specifically on unipolar depression, but it looks like there are associations with schizophrenia and inflammation, and even bipolar depression in the context of bipolar illness. Speed et al. Published in 2019 that one of the other mechanisms is that when people start having more body fat, particularly around somebody's gut, that can actually be causative of depression in some situations. And so we can look at the relative level of inflammation, not by measuring these inflammatory mediators yet, but we can measure something that actually comes from the practices of cardiologists. And that's a lab test called a C-reactive protein. And cardiologists measure CRP in people who've had heart attacks to get a good sense of the relative amount of inflammation in the cardiac vessels, and whether or not people need to have anti-inflammatory treatment in order to prevent another myocardial infarction. What we're seeing is a relationship between elevated CRP levels and certain mental illnesses. We know that people with mood disorders oftentimes have CRP levels over 3 milligrams per liter. In fact, a third of people with mood disorders have this abnormal lab test. When people have elevated CRP levels, we know that there's an association with a worse symptomatology, as well as a poorer prognosis and other comorbidities in the context of their mental illness. Now, the clinical applications of this fact are still being elucidated. We're seeing some trials, particularly one that's slated to be published at the end of this calendar year coming out of Cambridge University, where they're actually looking at medications that block the inflammatory mediators that we've been talking about. They're medications that currently are indicated to treat rheumatoid arthritis, like infliximab and tocilizumab, which block interleukin 6. And wouldn't it be interesting to see if by blocking this cascade of inflammatory mediators, we might actually be able to augment traditional treatments like psychotherapy and psychiatric medication treatment, or even better than that, make sure that people who have mental illnesses can control the overwhelming inflammation that goes along with it so that the course of their illness is improving. Someday, who knows, we might be telling patients from a psychiatric perspective, not only to do things from a lifestyle point of view that decrease inflammation, but to pop an ibuprofen in addition to their Prozac. We'll wait and see. Next slide, please. So let's shift gears and focus a little bit more on this theory and how it relates to COVID-19. Next slide, please. So there's an idea that COVID-19 kind of revs up somebody's immune system when people are directly infected with the virus themselves. There has been lots of discussion about something called a cytokine storm. Cytokine here refers to those inflammatory mediators that we've been talking about. And we know that COVID infection may actually overproduce the cytokines, which are part of this inflammatory cascade. Maybe that's one of the reasons why there's variability and such variability in the severity of illness and prognosis in people who contract COVID-19. We know that some people die from the infection, whereas we know there are others who don't even have any symptoms when they contract this illness. It also might be one of the reasons why steroids are helpful when people are hospitalized with respiratory problems. Internists and people who are hospitalists oftentimes treat folks with COVID-19 with dexamethasone, which is one of the steroids that inhibits the cytokine production that we've been focusing on so far. In Lancet, in November of 2020, there was a good study that showed 20% of survivors of COVID-19 infection developed new mental illnesses within 3 months of contracting the infection. Data out of CDC estimate that that percentage might actually even be a little bit higher than 20%, but this is what the research literature is purporting to date. So you can do the math. Out of the hundreds of millions of people who have contracted COVID-19, if 20% of those folks have the new demand for mental health services, you can just imagine that the second pandemic is only on its way. We're also seeing that people who are indirectly affected with the pandemic experience increase in their cytokine production as well. Certainly chronic stress in and of itself produces cytokines, and the decreased attention to healthy lifestyle choices that I want to focus on in the second part of our discussion today also likely exacerbate some of the problems in cytokine production. Next slide, please. So the second poll question. According to a CDC random dial survey in June of last year, the point prevalence of Americans who were seriously considering suicide was roughly 1%, 5%, 10%, or 15% of the people in the study. If you can make an educated guess as to which of these you think is the correct answer, we'll see what the overwhelming majority of you think. All right, so it's a pretty good distribution with 10% and 15% having the highest answers. This is a very intelligent group, obviously, but just as a sort of a punchline to this question, the correct answer is 10%. But the suicide completion rates in 2020 actually fell by 6%. Compared to completion rates for years prior. So we see this nationally in times with a lot of stress. When World War II is a great example. There was a lot more suicidal ideation in America during the national crisis, but the rates of completion of suicides tend to decrease even when there's an increased risk of suicidal ideation. Next slide, please. So we'll go through some of the epidemiologic information that the CDC has reported. We know that physical distancing and stay-at-home orders were really impactful for people who were indirectly affected from a mental health perspective by the pandemic. Again, these are data from June of 2020, where 41% of Americans reported some sort of adverse mental health condition that they directly related it to what had changed in the world during the pandemic. Of those, about 31% had anxiety or depressive symptoms that actually met criteria for a DSM-5 mental illness. Interestingly, and one of the things that we'll talk about from a case study perspective is the increase in people who turn to substances to try to modulate their emotional and anxiety symptoms. And it makes sense. If you're at home and spending a lot more time around alcohol or marijuana or prescription drugs, it makes a lot of sense that that might be an easy alternative way to try to cope, even if it is not a healthy decision to make. And then again, in this study, 11% of the people polled were seriously considering suicide. So to me, this is sort of a recipe for an over-demand in folks who are going to require mental health services in the next 3 months, in the next 3 years, in the next 3 decades. Who knows, because the story is still being played out. Next slide, please. Here's a third poll question, and I want to get a sense of, in this group, what the impact has been on our mental health. So if you think about February 2020 through today, do you think that your personal mental health has greatly improved, improved somewhat, remained about the same, declined somewhat, or greatly declined? And if you can answer that question and hit the submit button, we'll show the results in just a few seconds. So it looks like decline somewhat has taken the blue ribbon here with 31% of us responding that. I think it's going to be interesting during the discussion part to hear from people who reported that their mental health has greatly improved. And I would love to hear some more details and some examples from the 11% of you who thought that this has been an important time for your improved mental health and how that happened. Next slide, please. And so there's some obvious reasons why most of us have reported a decrease in our overall mental health. If you haven't really had a decrease in overall mental health, it's hard to sort of understand how that may have happened, because many of us have had what we in psychiatry call adjustment difficulties. I like talking about physical distancing rather than social distancing, because this is exactly the time when we need to have important social interconnections. And I think it's a bit of a misnomer to say social distancing, even though having some physical space in between us may be important. Boundary issues by far has been a huge component of decrease in mental health for many of us. If you're working from home and your office is your kitchen, how do you know when to stop working? And how do you know when to clean up your computer and your papers and to start cooking? And how does your employer know that you're meeting your goals because they can't check on you? And it's a lot of sort of boundary issues that have contributed to role clarity. Also, some people have reported too much together time. I think if your children were learning from home and you didn't have doors to slam when you needed to have some space away from everybody, that could certainly challenge somebody's mental health. And then the disruption of routine and the established coping mechanisms really turned out to be important from a behavioral perspective. And the American Psychiatric Association is looking at this very rigorously and has made some sort of preliminary recommendations of what we all can do in a non-technical, non-professional way to try to increase our resilience and to get back to some of the routine coping mechanisms that have been shown in research to be helpful from a resiliency point of view. Next slide, please. Now, we know that there are some indirect impacts for healthcare workers in particular that have been summarized and written about in the research literature. The big theme that continues to emerge is a relative lack of a sense of control. People who are responsible for helping care for people directly infected with COVID-19 may feel like they're impotent, that there's nothing that they can do to change the course of the illness or to prevent death. There certainly was a lack of information and transparency from authorities that we were looking toward for that kind of guidance. And when there was some guidelines that were issued, oftentimes there wasn't full agreement and full consensus within different institutions. And I think that that was very disruptive and very concerning for healthcare workers who were asked to translate that information for our patients. Having unpredictability is always difficult from a psychological perspective. And I think what we're hearing from a lot of healthcare workers is that the result of these senses was that there was a blunted emotional empathy, that it was more difficult to sort of figure out how to be empathic for our patients and our family members who were struggling, because much of our emotional attention and energy was focused internally so that we could get through it ourselves and continue to work and show up to try to help others. Next slide. So I want to remind you of an age-old study that helps explain a little bit how healthcare workers may have felt during the pandemic. And this is the classic shuttle box experiment to describe learned helplessness. So in this experiment, you know that there was a little cute puppy who was put on one side of a shuttle box, and the partition between that side and the other side was lowered. The floor of that side of the shuttle box was shocking, and the puppy did not like the shock on his feet, and so he was able to jump over the low barrier onto the other side of the box that did not have electrified floors. The second phase of this experiment was to put the partition up so high that the puppy wasn't able to help itself. The puppy got shocked on its feet. It wasn't able to jump over the partition. And eventually, the puppy learned that there was no way for it to be able to change the course of its experience of being shocked. The final stage was the researchers lowered the partition, shocked the puppy's feet, and the puppy did not free itself, even though it had the capabilities to do so. This is a classic kind of psychological experiment that shows after a while, people learn in situations where there's lack of information, there's ambiguity, there's a sense of a loss of control, to eventually stop doing things to try to change the course of somebody's future. And I think it is informative on what maybe some of us had experienced who were on the front lines of trying to care for people during the pandemic. Next slide, please. So there's some red flags that you might be paying attention to in people you love, in yourself, in your patients, that might suggest that people need professional intervention. Certainly thoughts of suicide raise the bar tremendously, and it's not just an adjustment reaction when people start thinking about suicide. When folks develop significant disability and they miss role obligations, or they have a sharp decrease in functionality, they don't show up for work, they can't meet expectations or obligations, that would be another red flag that this isn't just a coping problem, but that somebody may actually be developing bona fide mental illness. We're seeing the emergence of some significant serious symptoms of mental illnesses, including psychosis, vegetative depression, or even new onset mania in the patient population that we have in my program, that we think also may be directly related to the experience of the last year from a secular societal point of view. And so these are some of the emerging warning signs that I think suggest that even though many of us are experiencing difficulties from a day-to-day kind of perspective, there are a few of us who are developing bona fide mental illnesses that may require emergent or urgent treatment. Next slide, please. So with that in mind, I want to shift gears and spend the next 5 minutes or so just going through a case illustration of what happened in my program named Skyline Trail during the pandemic. Next slide, please. Again, I'm not trying to sell you on anything, including Skyline Trail, but in a sort of descriptive summary, Skyline Trail is a private nonprofit residential and intensive outpatient psychiatric program. We have 56 adult residential beds, 26 adolescent residential beds for people aged 14 through 17, and then 25 transitional living beds. And these are low demand apartments that are in the community where our staff are available to help coach patients, but that people go to school or to work during the daytime and they're not engaged in ongoing mental health treatment during the week. We also have an on-site integrated primary care services. Dr. Druss was instrumental in helping develop this about 15 years ago. Again, between 8 and 10% of our admitting patients have newly diagnosed physical health problems in our primary care clinic. And we see that when folks are able to get that kind of integrated care as part of their mental health treatment, they do better both from a physical health outcome perspective as well as an emotional and mental health perspective. We offer transcranial magnetic stimulation, and we have a very robust metabolic syndrome prevention program. So all of our patients in every level of service are asked to focus on healthy eating, on active living, on mindfulness meditation, on doing things that are humanitarian based for others, in addition to working on controlling their symptoms. The average length of stay in all levels of our care is roughly 3 months. So you can get a good sense of what the experience is like in this treatment program. Next slide, please. This is a picture of one of our campuses. We try to make it inviting. We try to make it look non-institutional. But what we do really focuses on using evidence-based interventions, and we're very measurement-driven. So in every decision that's made from a clinical perspective, there are at least qualitative and often quantitative data that go along with making that decision. And I want to give you some examples now. Next slide, please. So during the pandemic, these are data from March through December of 2020. We saw a 96% increase in patients, 96% increase in patients with a primary anxiety disorder. So these are people with generalized anxiety disorder mostly, but also panic disorder, agoraphobia, and we don't categorize post-traumatic stress disorder as an anxiety disorder anymore, but we did see a significant increase in people with PTSD as well. 66% of our adult patients aged 26 to 5 years old had a bona fide substance use disorder. And when we compare that to the numbers from 2019, it was almost double within that age group. We saw increases in other age groups as well, but it was the 26 to 35-year-olds who had the most substance misuse. At the time of admission, we do a series of tests and we measure hope for the future using the Beck Hopelessness Scale. And our average score at admission during this time period was a 1.64. So for those of you who know the BHS sort of range of scores, this is what we would categorize as being nihilistically preoccupied. People with a BHS score close to 1 3/4 really have a hard time imagining that they're going to have any future for themselves, let alone a healthy and happy future. And so this is a relatively significant finding at the time of admission. We had a longer duration of no treatment. So many people with schizophrenia who showed up had a duration of untreated psychosis that was months rather than weeks. Our lengths of stay during this time period were longer by about 10% than they were the year before. And notably, we had a decreased program completion rate. Many people had a difficult time engaging in the virtual things that we were offering. We switched to virtual group therapy in March, and it has persisted up until December of 2020. So I think that there are many lessons to be learned from these data, but all in all, it was a much more difficult year to engage patients in this psychiatric treatment program. 85 out of 280 patients who both admitted and discharged during this time period notably had a C-reactive protein level of greater than 4 milligrams per liter. This is, again, was statistically significantly higher than the number of people who met that criterion in previous periods of measure. Next slide, please. Staff burnout became really apparent. There were no staff who took personal time hours off initially. So up until June of 2020, there were no staff who went on vacation. And I think that that was problematic for a lot of obvious reasons. We were open the entire time of the pandemic and we were treating our residential patients in person, but there was a very rigorous test, isolate, retest admission protocol for our new patients. We would test them, have them isolate in one of our facilities, literally not having interactions with others, and then retest them before they integrated into the therapeutic milieu. Overall, we had 21 cases, and the majority of our cases during that time period were staff people, not patients. We obviously couldn't control what our staff did on their personal time in the community. Next slide, please. We did a lot of things from a resiliency point of view. We had periodic public health updates and information sharing. Every week I would do sort of a fireside chat where we would meet and talk about what the latest data showed and what we were trying to do to make sure that our community was safe. We ended up requiring that people started to take time away from work. And I think from the staff's perspective, this was a really important nudge to remind everybody about the importance of work-life balance. We also initiated a staff wellness program. We offered virtual meditation and yoga for free. We had care packages delivered to our staff who came in. We offered hazard pay for folks who were on the front lines working with our patients. And we had, as I mentioned, weekly time to have supervision. We began vaccinating our staff in December of 2020. And as of yesterday, we have had 92.7% of our staff voluntarily take the vaccine. We had the opportunity also for work from home days for direct care staff so that there was a little bit of equity for people in accounting and the business side of our organization who could easily work from home the entirety of the pandemic. And we wanted people to feel like they were being treated fairly. We offered free lunches for staff. We had a relaxed dress code. And we made it easy for staff to get tested before immunization was an option. We had a memorandum of understanding with a local clinic, and eventually I bought a machine. So we have an on-site COVID testing option for our staff at work itself. Next slide, please. And so I want to end with just a bit of some recommendations of what we all need to focus on, whether we're healthcare workers or not, to help maintain our resiliency and ultimately to decrease the global uncontrolled inflammation that we started our discussion with. Next slide, please. So I want to end with one poll question and then give you the top 10 list. And this is the last one. The best strategy I used during the pandemic to modulate my mood and anxiety has been which of the following? Virtually connecting with my support system, exercising, meditation, healthy cooking, or another option that was not listed up on this screen. If you can answer this question and then submit the results, we will produce the outcome in just a second. So connection with others had 40%. And I think that that's really what other researchers are reporting, very close to that even though it wasn't ideal, having a system of people who can share your experiences is crucially important. And we know that that's true in patients with mental illnesses as well. The Mental Health Directors Association has shown over and over that social interconnection among patients, particularly people with psychotic disorders, is the best predictor of recovery. And I think we see that in our regular lives as well. Next slide, please. So this is a top 10 list that was developed by the American Psychiatric Association, not by me, of things that are inflammatory triggers that the APA has suggested we want to control by doing things from a lifestyle perspective to mitigate these things. And I want to focus on just two of them and end my discussion with these two. Next slide, please. The first one is the importance of exercise. My friend Steve Sharfstein at Shepherd Pratt in Baltimore did a study recently where he looked at exercise in helping the recovery of patients with schizophrenia and found that a certain kind of exercise is really anti-inflammatory and produces better impact on folks with that mental illness. And the basic scheme is to shoot to exercise 4 times per week for at least 30 minutes per time, but to alternate between strength training exercise using large muscle groups and HIIT. And what HIIT is high intensity interval training. And you really want to do HIIT by starting off with your heart rate at resting levels, and then having very vigorous cardiovascular exercise to get your heart rate up to the target level. And to do that for 20 to 30 seconds before you allow your heart rate to return to what it was at rest. And if you remember the data that we started with about people with depression having decreased heart rate variability, the idea is that this kind of cardiovascular exercise trains your system to be able to improve the responsivity of heart rate variability, which we think is inextricably associated with mental health. Focusing on large muscle groups in and of itself is anti-inflammatory. So the larger the muscle groups, the more anti-inflammation that there is, because actin and myosin fibers moving over the top of one another decreases those mediators that we've been talking about. Next slide. And then controlling weight turns out to be really important. Macrophages live in adipose tissue, so the more adipose cells you have, the more macrophages you have. Next slide, please. And then finally, I'll end with two things. One about smoking. We know that paper cigarettes and vaping produce at least 210 inhaled pollutants that are very inflammatory. So it's not really the stimulant nicotine that is the biggest problem from a mental health perspective, although it does some things on the nicotinic receptors that might desensitize them in the long run. It's that there's a lot of inflammation that goes along with smoking. Next slide, please. And then finally, diet and healthy eating turns out to be crucially important. The Mediterranean diet is probably the most anti-inflammatory we know of. There are studies right now looking at providing supplemental omega-3 fatty acids for people with mental illnesses, particularly treatment-resistant depression, that show when people have between 4 and 6 grams of omega-3 fatty acids, there could be some advantageous clinical outcomes that having that diet and that supplement may confer on somebody who is otherwise in treatment. So I'll end with a partial bibliography and open it up for questions and discussion. And I want to thank Dr. Druss and Emily and everybody at the Southeast MHTTC for inviting me to talk about this really exciting and very important topic, and for all the great work that you're doing to help the mental health community. So with that, Emily, I'll turn it back over to you.
All right. Thank you so much, Dr. Kotwicki, for that amazing presentation. Everyone, we have reached the Q&A portion of today's webinar, so please feel free to submit any questions you may have for Dr. Kotwicki by typing them into that Q&A feature on your screen. I did see in the chat that we had one question from a participant asking about the recording of today's webinar, saying that they had a little bit of some shaky internet. Yes, this webinar is being recorded, and the recording of the webinar along with Dr. Kotwicki's slides will be made available on the Southeast MHTTC website in about 3 days' time. So you can be on the lookout for that. So if you missed anything, it will be recorded and you can access it later. All right. Just giving everybody a little bit of time to get their questions in.
Emily, would you be able to stop sharing your screen so I can look at the chat function as well? Thanks.
Sure. It looks like we do have one that was just entered into the chat. Were the 20% who developed mental health issues during COVID hospitalized? In other words, did they have a serious illness?
So the results that were published in the Lancet were for both people who were hospitalized as well as people who were not hospitalized. And so the severity of the impact of infection doesn't seem like it was the variable that produced the increased risk of mental illnesses, or at least some kind of mental health impact in people who were directly infected. It looks like it was an independent outcome from the severity of illness. And so, I guess logical next question is, for people who were asymptomatic or didn't even know that they had infection at all, what is the rate or the risk of those people having an increased, sort of reactivity down the road? And I certainly don't know the answer to that question, and I don't believe that there are any good studies that answer that question of which I'm aware today. I think we're going to have to stay tuned for the answers for a lot of these kind of future-oriented questions, because I just don't think anybody knows what to expect.
All right. Thank you. One. How much omega-3 do you recommend for mental health treatment?
So omega-3 is sort of a bit of a question that is still being assessed. People like Mark Rappaport and others have looked at supplemental omega-3, and it looks as though people who have major depressive disorder that is not responsive to traditional treatment need to take a relatively high amount of omega-3s, like about 4 grams a day or higher, in order to have an impact on the course and prognosis of their illness. We oftentimes in my patients don't dose it that high, but we work with our catering staff and the people, our dietitian who plan our menu for the patients who live in our residential program, so that we really do focus on getting fatty acids and omega-3s through food intake. But when we prescribe it as a supplement, we do 1 gram of omega-3 ethyl esters 2 times per day. So it's a total of 2 grams a day. We don't go quite as high as 4 grams yet. But I think if that research is reproduced and it turns out that the application is important, then we'll have to change our dosing.
All right, thank you so much. Our next question in the chat: are there any routine labs a primary care doctor could obtain to assess levels of inflammation, hence gauging risk level of mental illness?
Yeah, the lab test that is becoming really well known and used is the C-reactive protein. It's cheap. It's just a venous stick, so it's easy to collect. The results are available to us within 48 hours, and we don't have an on-site lab. We send it to either Quest or LabCorp. And I think that the research literature is starting to have more information about what to do with the results. Heretofore, you could check and see that somebody has seriously high CRP levels and then have no idea what to do with that information. Now we know from a psychiatric perspective that those are patients we're going to have to keep our eyes on closely, because they oftentimes don't respond to the usual interventions. And we are enrolling those patients in all of the lifestyle modifications that I described to you today. So they automatically get started on a personal training exercise regimen using HIIT coupled with strength training exercises. They all get automatically enrolled in our healthy eating program. They all do mindfulness meditation. We use a modified meditation program that's called compassion-based meditation, where instead of people thinking about nothing or focusing on their breathing or something, when our patients meditate, we ask them to think kind things about others, particularly people that they're struggling with in contemporary relationships, and to focus their cognitive efforts on those topics. So those are all things that have been shown to be anti-inflammatory. And I think that those are low risk. It's not putting somebody on Celebrex or infliximab or something like that. They're low risk and potentially could be very high yield. So I would recommend measuring CRP and using that information accordingly.
Okay, thank you. Our next question from the chat: could the percentage of completed suicides be due to people living in closer quarters than usual during the pandemic?
It's a really good theory, Monica. I don't know, and I'm not familiar with any data that helps support why in periods of national stress and Sturm and Drang that the suicide completion rates tend to go down. I think, the idea that I have been taught, although I don't think that there are data to support it, is that when somebody has an increased sense of nationalism, And if sort of, we heard the phrase, it turned out to be a catchphrase, we're all in this together. That's a little bit reassuring because we know that people who are isolated and hopeless and helpless and nihilistically preoccupied are at an increased risk for a suicide attempt and ultimately of completing suicide. So I think it could be, a sense of existential belonging that I described. It could be that there's more forced social interconnections with family members and other people in the same home. I don't really know exactly what the variables are. But again, we saw that kind of ironic data from the pandemic most recently, but we've seen this during national wars. We've seen it when there have been other tragedies that it produces this ironic decrease in suicide completions. So it'd be really interesting. I'm a big fan, as I know this group is, of looking at strengths and why some people can make it through really difficult situations. And let's learn from that so that all of us can generalize those skills to our lives.
All right, it looks like we have time for our final question, and that is going to be, how do you suggest therapists or counselors prepare for the incoming tidal wave of needed care?
Well, it would be great for all of us to chip in and open a new medical school and a new counseling school and train psychologists. And I don't mean to be flip in that answer, but I think it's going to be a two-pronged approach. One, we just don't have the professionals available to accommodate the new demand. So how are we going to get more people to go into mental health? And how are we going to train them to use evidence-based interventions to manage this demand? The second prong is what could we have learned from the pandemic that could make the provision of services easier? There's a really interesting article from my perspective in the New York Times on Sunday, where somebody talked about the virtues of continuing telepsychiatry and telemedicine, and that for a large number of therapists, doing remote counseling actually increased the show rate for patients. It made patients more engaged in the therapy that they were able to do. And I think it may have expanded the footprint and the ultimate reach of our profession's ability to provide in-home counseling services to people who need it. So maybe that's something that we should continue to do outside of the auspices of the pandemic. And if the national board and local composite boards decide that they want to change licensure regulations and the geographic constraints of providing services across across state lines, that could be a really nice outcome of a horrific event. And I think, from a medical student training perspective, which is what I do, we need a formal curriculum about self-care and work-life balance. And it's something that we talk about, we throw around those terms, but we don't train people how to do it. And when you get a bunch of neurotic people who are excited about getting A's in a room together, that's a missed opportunity to talk about the importance of caring for yourself so that you can better care for the patients we're privileged to serve.
All right, thank you so much. That is all the time that we have today for allotted questions, and that is going to be it for our webinar. The Southeast MHTTC thanks you for your participation in today's event. We value your feedback and invite you to evaluate us today. Please complete a brief SAMHSA required survey by visiting the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will automatically be redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you will have the opportunity to download a certificate of attendance for your records. Please allow about 5 to 10 seconds for your browser to redirect you. Again, the Southeast MHTTC appreciates your participation and your feedback. Dr. Kotwicki, we appreciate you for this wonderful presentation and for answering our questions. Please, everyone, visit our website to learn more, and this will conclude today's presentation. Thank you, everyone.